Good morning, good afternoon, and good evening, everyone. We'll get started in just a moment. Thank you so much. Good morning, good afternoon, and good evening, everyone. Thank you all for joining us for Vaccinating the World, Can We Achieve It? A webinar sponsored by the Global AIDS Policy Partnership in commemoration of World Health Worker Week. My name is Alex Vance. I serve as the Senior Director of Policy and Advocacy for the International Association of Providers of AIDS Care and the Fast Track Cities Institute. I also have the pleasure to serve as one of the 3 co-chairs of the Global AIDS Policy Partnership. Thank you all for joining us this morning. It's been done to ensure that COVID-19 vaccines are available and monetarily accessible to low and middle income countries. The world is careening toward a preventable crisis as doses arrive in capital cities without the workforce and supply chain logistics necessary to meet our goal of vaccinating 70% of the world by the middle of this year. Many health systems in countries at all income levels operate at razor-thin margins under normal conditions, with low and middle income countries falling far short of the WHO recommended number of health workers by population. The demands that COVID-19 has made of the health workforce have over-leveraged existing resources and led to unprecedented cases of burnout and overwork, and in many cases, those expected to deal with this massive burden are unpaid or poorly paid. Additional national and international financing must be mobilized to ensure that vaccine delivery is equitable and campaigns are successful. We're joined by an amazing panel of individuals today, and I'm very happy to have them on. We have Shifa Sikder, works with CARE as a senior technical advisor in health, supporting technical programs. She previously worked for USAID's Global Health as a senior technical advisor, supporting global and bilateral health projects. She completed her master's and PhD in epidemiology from the Johns Hopkins Bloomberg School of Public Health. She is an active member of the Frontline Health Worker Coalition through her role in CARE. Since January 2021, Dr. Anjali Agrekar has been serving as the acting U.S. Global AIDS Coordinator, where along with her team, she leads the coordination, oversight, and implementation of the U.S. President's emergency plan for AIDS relief. to ensure that all its activities and resources, including its annual budget of approximately $6 billion implemented in over 50 countries, is as impactful, effective, and efficient as possible. She has been with PEPFAR since its inception 19 years ago and also serves as the US board member to the Global Fund to fight AIDS, tuberculosis, and malaria. Anjali has dedicated her career as a public servant to global HIV/AIDS, women and girls' health, and global public health development. Dr. Mukid Shakuba-McLeod has over 25 years of experience in medicine, epidemiology, international health, and development. She has managed several public health projects, including 4 USAID-funded projects. Her areas of expertise include internal medicine, infectious diseases, disease surveillance, and research. She has worked internationally and domestically and understands the complex health requirements for effective interventions and action at both of these levels. Mukid is the project director for the USAID Discover Health Project, which supports health service delivery and social marketing programs in Zambia. She is also the JSI Zambia country representative. Dr. Amani Sayam is a statistician and technical officer at the World Health Organization's Health Workforce Department. Thank you all for joining me this morning, and we look forward to what is sure to be a rich conversation. To start, I'm going to kick it over to Shafa at CARE for a presentation on data and workforce needs.
Thank you, Alex. And it's really great to be with this panel today to round out World Health Worker Week. I will just give us a brief overview to kick us off focused on the costs of vaccine administration, opportunities and challenges with a focus on health workforce. Next slide, please. Workforce. Our coalition focuses on frontline health workers. The reason is that these frontline health workers are often the bridge between the health system and communities. Especially when we think about reaching marginalized and vulnerable people, frontline health workers are often pinnacle and trusted members of their community who can reach hard to their populations. Next slide, please. Data on health workforce that is pulled from WHO, particularly their 2019 report called Delivered by Women, Led by Men, which was a gender equity analysis of the global health workforce. These reports call attention to the global shortage in health workers, particularly in nursing and midwifery. This report also highlighted the fact, which I'm sure many of you have heard by now, that women account for 70% of the health workforce globally. Yet their roles are often in more undervalued positions and not in management and leadership. When COVID-19 vaccine rollout began across the world, health workers were among the first groups eligible for vaccination. If we expected equity in vaccine distribution, women should have been of those who received vaccines initially, given their composition of the health workforce. Next slide, please. What we saw, however, was a gender gap in vaccinations globally in initial rollout. Overwhelmingly, the majority of those who got vaccinated in low and middle income countries were men. CARE documented that women face challenges in accessing health services, mobility, as well as concerns about other health effects from vaccination. We also know that the data on gender disaggregation in vaccination was spotty. I've cited here statistics from Global Health 50/50. And here we see that only 47 countries have even reported sex disaggregation in vaccination. In the Asia region, only India and Bangladesh consistently report sex disaggregation in COVID-19 vaccination. And of those two, in India, only a third of those getting vaccinated with COVID-19 are women. We have some recent promising case studies of countries that are closing the gender gap in vaccination, And they're doing so by integrating COVID-19 vaccination into other essential health services. In Zambia, we've documented where CARE has been able to support the incorporation of COVID-19 vaccination into antenatal care, family planning, and growth monitoring, which has helped increase the number of women accessing COVID-19 vaccines. In Tanzania, we have a case study on the integration of vaccine into routine maternal and child healthcare visits, which is especially effective in reaching women since they're often the ones who take children for their routine healthcare visits. Approaches was community engagement focused around the concerns that women had about the effects of vaccine on fertility and other rumors that were going around. And this was all healthcare workers. Just because healthcare workers were the first eligible group doesn't mean that they were all comfortable being the first ones getting vaccinated. And so we focused our outreach on question and answer sessions, really engaging the concerns that healthcare providers had and providing forums for discussion around these issues. Next slide, please. Here I'm going to get into costs, and I'm citing information from a report that we released last year called Our Best Shot. And we've documented our methodology in detail, but for the sake of today's conversation, I'll just take you to our top lines from this report. We estimated that the true costs of delivering COVID-19 vaccines are 5 times higher than what global estimates, other global estimates say are the actual costs of vaccination. And we estimated that for every dollar a country or donor government invests in vaccine doses, $5 is needed in delivering the vaccine. Half of this cost is for funding and supporting frontline health workers, the people who administer the vaccines, connect communities to health services, and get people shots. Often the funding for COVID-19 vaccination is for the doses, not the actual cost of getting shots in arms. Next slide, please. Estimate in cost is for the staff, funding, and infrastructure needed to truly deliver vaccine doses. In Nepal, for example, we documented a costing case study that 70% of the cost of vaccine delivery is for the human resources in the health workforce. 12% is community mobilization. And the Minister of Health said in this case study, the biggest challenge to COVID-19 vaccination is no longer supply, but delivery. In Zambia, in the 3 districts where CARE works, a lot of the investment was in data systems. Half of the health facilities that CARE supports had neither power nor internet. So CARE invested in data systems to be able to record the vaccine doses being administered, to be able to contribute to the national tally of vaccine doses given out. Next slide, please. Data from an analysis that CARE conducted with Booz Allen Hamilton called the Case for Investment in Global 19 Vaccine Response. And here, the estimation is that the cost of not fully funding global COVID-19 vaccination distribution can damage the US economy by hundreds of billions of dollars. And if we look across wealthy nations, this amounted to, in this study, amounted to about $4.5 trillion loss in economic estimates. And this was due to many different effects of not fully funding COVID-19 vaccination. We see in many cases increased food insecurity, loss of education, decreases in childhood immunization, and other health effects as well. And if we look at the opportunities, we know that fully funding COVID-19 vaccination makes it possible to reach the last mile, particularly with investments in health workforce. And it really helps optimize our vaccine supply because we've seen so many case studies where vaccine doses have been delivered in countries, but have expired or not been used because the countries did not have the systems or the funding for their workforce to actually be able to administer the vaccines. Next slide, please. An example of what empowering frontline health workers looks like. Here we have an example of a skilled health entrepreneur in Bangladesh. This is a social entrepreneurship model in a hard-to-reach remote community in health entrepreneurs existed prior to COVID, but during COVID, they continued to provide services in community engagement, product availability, and ensuring availability of commodities and supplies, as well as their household outreach. These women are integral parts of their community, and we saw that in their local elections, 10 of these women were actually elected to their union councils. This is an example of women responding in emergencies, but also valued at various levels of their system in their communities. Next slide, please. Summary, for the costing studies, we've seen that the actual costs of distribution are anywhere from 5 to 7 times higher than current global estimates. We see a gap in vaccination, a gender gap in vaccination, although many contexts are closing this gap by integrating health services. Next slide, please. So if we come to our recommendations out of all these reports, it's about fully funding COVID-19 response, which is underpinned by adequately supporting frontline health workers. As we've said, of the investments made in vaccine delivery, half of this is needed for support to frontline health workers, which includes ensuring equitable pay, safe and supportive working conditions, and other support for frontline health workers. We also not the last pandemic, so investing in national vaccine readiness, community engagement, and surveillance is essential to reach the last mile, the hardest populations. We know it's much more expensive and much more difficult to reach the last 20% compared to the first 20% of the population. And frontline health workers are key in this goal. Next slide, please. Okay, here I've presented what are the goals of supporting frontline health workers in COVID-19 vaccination. We want to ensure equitable vaccination so that nobody is left behind. And in adequately supporting frontline health workers, we can achieve community mobilization, sustained access to health services, and look at transforming our health leadership structures for more women in health leadership positions. Thank you. Next slide, please. Here I've just provided some of the resources for the reports I've mentioned, and I'm happy to provide those in the chat as we go forward. Thank you.
Thank you so much for an excellent presentation, because it's a lot to talk about today, especially about regarding the shift in focus from supply to delivery and how we can all do that together. I do have a few questions for the panelists, but I do want to remind all of our participants, if you have questions, please put those in the Q&A function, and we will get to those shortly. All right, to kick things off, Anjali, how has PEPFAR's workforce been handling COVID-19 vaccinations, and are there plans for continuing that support as vaccine doses reach PEPFAR countries?
First, well, let me just say thank you. Thank you, CARE. Thank you, AVAC. Thank you to the panelists for being privileged to be a part of this group today. It's such an important topic that we're discussing, and I really appreciated, Shaifa, the presentation that you laid out. To answer your question, Alex, how has PEPFAR's workforce been handling COVID-19 vaccinations, and what are our plans for continuing to support? it really, we've come at it from the lens of how do we do everything that we can through PEPFAR to protect our gains in HIV for the people that we serve and the healthcare workers that serve those people. And so it is and it has been in our best interest to make sure that COVID vaccination is rolling out, that coverage is increasing for the people that we serve. As some of you may know, PEPFAR supports nearly 300,000 healthcare workers, and these are various cadres, clinicians, nurses, community health workers, which are critical, laboratorians, but essentially clinical health workers and ancillary workers. And they have been deployed, frankly, over the past 2 years. We've been working hard, even before vaccines were rolling out, we had been working hard to utilize and leverage that healthcare workforce, which is so critical on COVID screening, testing, infection prevention and control. And then when vaccines were available, we quickly mobilized to help on vaccine readiness and administration, really getting shots into arms. So for example, last year, approximately 30 to 35% of that healthcare workforce that we are supporting for HIV has been leveraged to do both HIV work while doing some sort of COVID effort. Again, there is a interest that we have to make sure that we're protecting the HIV gains and doing everything that we can in our power to help address COVID-19 as well. In terms of plans to support vaccine doses as the future rolls out, we continue to do everything that we can to utilize that platform. And it's not just the healthcare workforce, as Shafa described, and really talked about the various aspects of service delivery. It's healthcare workforce, it's infrastructure, there's so many pieces that come to supply chain. There's so many pieces that have to come together in a networked way to best deliver. And so there are efficiencies to be gained by utilizing the existing work that we're doing through PEPFAR to help push forward on the COVID response as well. So I'll stop there. Thanks, Alex.
Thank you so much, Anjali. My next question is for Dr. Siam. What workforce needs does WHO estimate we are lacking? And what are the implications of that gap for global vaccination efforts?
Thank you very much. It's a pleasure to be here, and thank you for having me. I think Anjali and Shaifa made my job easy. They've laid the grounds. This is what I would like you to consider, that this is the biggest vaccination program in the history of public health. Never before has there been a program rolling out asking vaccination regressively from one age group to the next to the next. So imagine that was a situation, a very fast onset, and with the big sort of achievement of vaccines so quickly, it landed, or at least was not well anticipated from many of the countries, exactly as Shaifa mentioned, that vaccines would arrive and not have the adequate channels and individuals, manpower to actually move it about. And this is definitely a very high cost. Let me just take you a step back. WHO in this area moved quickly to work with partners, PEPFAR, Gavi, the Global Fund, and we put our heads together to see how fast can we anticipate the health workforce need, the surge needed, to come up with realistic numbers, to preparation of all sorts, from costing to distribution, to, as Anjali said, repurposing the staff, making use, leveraging whoever is there to try and put them ready to do whatever possible to work between the two service delivery models, their usual everyday work alongside the vaccination. So I'll just briefly throw some numbers at you. I'm sorry to have to do that because you're speaking with a statistician. We took stock of the numbers and the figures coming into WHO about the vaccination coverage. By January 2022, we had about 34 countries out of the 194 who met the 70% target. But this should not come as a surprise to you because most of these countries are high-income countries. Left are about 47 countries did not yet achieve the 50% mark of coverage, but are on target. They are trying their best. We needed to close the analysis by December so that we can make these projections for the sheer sake of sizing up what are the requirements going forward until June 2022. Of course, as you can imagine, we have 113 countries who did not yet reach, that's almost 2/3 of the global number of countries that we monitor. They haven't reached the 50% mark. And hand on my heart, I say it's very sad to say that not even about 61 of those did not even reach a quarter of their population with the coverage needed for vaccinations. So going forward, what does it take? You have to imagine a total of 2.9 billion doses will have to be administered by June 2022, as of January to June. And those, in our estimation, would require a global workforce of about 1,830,000,000 workers on average. Of those, about 775,000 are vaccinators, 704 are support staffs, 352,000 are community mobilizers. As you've heard, these are individuals communities are already familiar with, but they are just as needed to mobilize the demand for vaccination. That's the hardest part to also put together. In sum, we are thinking of a scale up that would be to the range of 745,000 health workers that should be dedicated to vaccination. And this is to achieve the 70% mark. And they would cost an average of about $2.5 billion to recruit and sustain for the period of time. We went a step further and we said, June is around the corner. If we push it, the 70% mark by December, the cost is still significant because you are in a way mobilizing the biggest workforce to deliver vaccines within a very short, unprecedented timescale. So if I leave you with any thought, just think of the 740,000 that would be needed, the average cost of 2.5 billion for those by June, which might extend to 3.2 billion if the time frame extends into December 2022. One last thought, all of what I've told you will feature in a paper that we have submitted in a multi-partnered contribution, and hopefully I will pipe on news to you of whether the paper is accepted. Of course, it's under review and publication. Thank you very much.
Thank you so much. That gives us a lot of information to work on, and our marching orders are incredibly clear as we try to get to the benchmarks of vaccinating the world. My next question is for Dr. Chikuba McLeod. What have you seen in Zambia as increased burdens have hit the health workforce there with COVID-19 mitigation efforts? And what do you envision for the next 2 years if resources remain at status quo?
Thank you very much for that question. And thank you to the other speakers, Shefa, Dr. Anjeli, Dr. Siam, for your comments. To answer the first part of the question, can you hear me?
Yes, Muga, we
Hello,
hear.
Alex, can you hear me?
Yes, we can hear you.
Okay, thank you. Sorry about that. My connection is a bit unstable. To answer the first part of the question, without a doubt, COVID-19 has imposed severe strains on the health workforce in Zambia. Our health workforce was already overstretched before we began scaling up COVID-19 and even before COVID-19. Over the past several years, Zambia had significantly scaled back public sector employment, including in the health sector. The Ministry of Health has an approved staffing establishment of just under 140,000, but currently employs 64,000 workers, representing 46% staffing levels. As the population healthcare needs grew, the health workforce was forced to adapt and absorb the extra demand, becoming more and more stretched. The COVID-19 public health emergency, therefore, came at a time when the country was already dealing with healthcare worker shortages to deliver essential health services across the different levels of the health system. Like happened in many countries, during the peak of COVID-19, the health workforce experienced severe strain from increased workloads in difficult working conditions, from COVID-19 infections among health workers, and from the general impact of the crisis on mental health. When vaccines became available in the country in April 2021, we required our already overburdened workforce to add on scaling up COVID-19 vaccination. What complicates this for us is the fact that our COVID-19 vaccination program is predominantly a push program, often requiring healthcare workers to leave health facilities to deliver vaccination services through outreach in communities, door to door, and in congregate settings. These workers, therefore, are being required to increasingly divide their attention between facility-based service delivery and outreach service delivery. Adjusting services to outreach-based models demands additional health worker time, and it is expensive. I must hasten to add that when the shift to models for health service delivery is fully resourced, it can be a very positive development, moving us closer to person-centered care, taking services closer to where people are. In Zambia, we have significant resource constraints, which leads me to the second part of the question of what would happen without additional human resources. Public health emergencies are sometimes unpredictable. In Zambia, as we were preparing for a massive April campaign to push towards 70%, another public health emergency surfaced, and suddenly we had to undertake massive polio vaccination in March and April, pulling from the same healthcare workers we were going to use for COVID-19 vaccination. We were forced to postpone the COVID-19 vaccination campaign to May because we do not have enough health workforce bandwidth to run the two campaigns concurrently. We also had to build enough time between the two campaigns to allow the health workers some recovery time from the polio campaign. Without additional healthcare workers over the 2-year time span looking forward, given the sheer scale of vaccinating 8.7 million people by June to get to 70% and sustain this coverage, our healthcare workers get stretched to breaking point. Delivery of all health services suffers critical gaps. Patients and clients don't get the services they need, and health outcomes worsen across the board. We would slide back and lose some of the hard-won health gains of the past decades and begin to feel the negative developmental impacts of poor health status socially and economically. In Zambia, we have some opportunities on the ground that position us to succeed in getting to 70 while also safeguarding our health workforce and delivery of essential health services. Firstly, even while health worker recruitment was scaled back, there was growth in private sector health worker education, leading to continued supply of health professional graduates who are currently not in employment. We estimate that we have between 15 and 25,000 professionals who are yet to be absorbed by the health system, this is a significant supply side opportunity. Secondly, our COVID-19 response, including the vaccination program, is well coordinated by the government through the Ministry of Health and receives significant resource support from cooperating partners and other donors. And this is important. Government and other partners sit at the table and determine where the gaps are and work collaboratively to bridge gaps, not always fully, but to the extent possible. US government support channeled through USAID, CDC, and other US agencies, including PEPFAR support, is providing significant human resource support for COVID-19 vaccination in Zambia. This is in addition to support from other cooperating partners, including WHO, the World Bank, the Global Fund, Gavi, and the UN agencies, to mention a few. At the implementing partner level, under USAID Discover Health, we are currently recruiting from the pool of currently unemployed health professionals to add close to 700 COVID-19 vaccinators on short-term consultancies to help cushion the impact of the surge to 70% on the current health workforce and on delivery of essential health services. Meanwhile, for the longer term, the Ministry of Health is also recruiting, and we will add about 11,000 health workers, nurses, clinical officers, doctors in the next few weeks and months across all 10 provinces. This is a significant addition that will increase the elasticity of the public sector health system and push us from 46% to 54% staffing levels. This is not nearly enough, even with this addition. Getting to 70% and reducing the impact of future waves of COVID-19 is an imperative for us, especially as we approach the cold season, during which we experienced the most brutal wave of COVID-19 in 2021. I'm optimistic that the opportunity to tap into out-of-work health professionals for the short-term workarounds to increase the health workforce, the ongoing recruitment to increase permanent MOH health workforce, and the coordinated response stewarded by an adaptable MOH leadership will get us there without completely burning out our current health workforce and collapsing the delivery of all essential health services. Thank you.
Thank you so much. I really appreciate the salient points about burnout among healthcare workers. It's something that has been reported worldwide, and it's incredible that the steps that are being taken in Zambia to counter that. So thank you so much for that response. Another question for Anjali. How is PEPFAR positioned to best deliver COVID vaccines in priority countries and municipalities? And what will be the impact on the HIV workforce if vaccine delivery is not financed?
Thanks so much, Alex, for that question. And I'll mention a few things. First, as I said previously, we've come at this from the impact that COVID has had on the HIV response, and then how do we best mobilize the existing infrastructure that we have to respond. Winnie Byanyima, the executive director of UNAIDS, and I put out a piece yesterday on World Health Day related to the HIV response that's threatened by COVID and how we can fix that, how we can mobilize together. It's certainly a partnership. Dr. Chakuba McLeod noted it's the multilaterals, it's the governments, it's civil society, it's across the US government, all working together. So how is PEPFAR best positioned? Again, there are efficiencies to be gained. When I looked at when Shefa shared the number of 5 times higher cost related to service delivery of those vaccines, we have to think about, well, how do we do this more efficiently? How can we do this more efficiently? Where PEPFAR is in 55 countries around the world, and with the infrastructure and the systems and capacities that have been strengthened over 19 years of implementation, again, these are country systems, country workforce. the access that is already there in thousands of health facilities and clinics and communities across these countries, the trusted relationships that exist between the US government and partner governments and multilateral partners in civil society, but most importantly with clients themselves, with the people we serve. That has been critical. Amina, you mentioned, that the COVID vaccination will be among the largest scale vaccine efforts ever. And you're right. So the question then becomes, well, how do we use access that we have to people in different ways? Because this is no longer just, for the 0 to 5, children that we have easier access to. This is, how do we access populations across the swath of the age groups? And so again, when we think of PEPFAR, we have access to people. We have access to various age ranges in facilities, in communities, through adherence clubs, through mobile clinics, through work that we do with circumcision, through work we do with HIV prevention. These are access points to people, people-centered services that are important. I think I loved the piece that you were describing, Muka, in Zambia. And I think just one example of the power of when it all comes together, what's possible. In Zambia, for example, with incremental resources that PEPFAR received through the American Rescue Plan Act in 2021, we were able to mobilize in rapid form, using those trusted relationships, the work that we do on the ground with the government, with multilaterals, with implementing partners, and with communities, to quickly mobilize across 500 health facilities where we're already working in HIV across the 10 provinces in Zambia, as part of our work for HIV, to mobilize on vaccine delivery, getting shots into arms. In a matter of months, 2 million vaccines, COVID vaccines were administered. And that is because it's the ability, and it was weeks that happened. It was the ability of moving quickly and utilizing existing resources. The last point, related to what will the impact be on the workforce if vaccine delivery is not financed, well, it'll be detrimental. I mean, we need incremental resources. We need resources to continue to move forward. We've been doing everything that we can, and we've been innovative and in adapting our services and trying everything, but resources are required. We need to increase the pie of the healthcare workforce. We need to increase resources for vaccine delivery. But again, there could be efficiencies if and incremental resources could be utilized if we lean on existing infrastructure that exists. Thanks, Alex.
Thank you so much, Anjali. The points about leveraging people-centered services and using those multilateral coordination is exactly where our bread and butter sits, and that's exactly how we're going to get to the end of, or closer to the end of, this pandemic. I have a couple more questions for each of you, but I want to make sure that we have time to get to the audience. I'm going to try to make these as quick as possible. So, Dr. Siam, which countries and populations are least resourced for vaccine delivery, and what do they need to achieve our goal of vaccinating 70% of the world this year?
Thank you, Alex. I think, as you could see or you could hear from both my panelists and my colleagues, countries that are most vulnerable are countries that are already with existing severe health workforce shortages. What WHO did is we approached it via different angles and elements. The first thing we've looked at, and it might not be the most obvious sort of determinant, was to look at the correlation, and maybe in future meetings we could elaborate on this, between what we call the Universal Health Coverage Index and the national, unfortunately, we don't have scope to actually go subnationally, the national health workforce densities. We went a step further, not only including the traditional trio, I call them, which are doctors, nurses, and midwives, but throw in the pan pharmacists, because you did hear it from Dr. Luca from Zambia, that they are trying to utilize as many individuals who can help in this, and hence meaning expanding the scope of those who could help. What we see is that we needed to have a bit of a protective measure, what I call the seat belt, around countries that are most vulnerable, where their UHC index is below 50, that's a 50-point structure or scope, and who have a health workforce combined density of less than a certain threshold, 48.5. And for those countries, we raised the alarm. We said among those countries, we would recommend not deploying or redeploying or repurposing more than 5% of their workforce. Because if they do so, prognostically, you will witness not just a kind of a fallback or a kind of a loss of gains. You are putting at stake the whole collapse of the health system. What worries us about COVID-19 is that it's a protracting emergency. It's a protracting crisis. We think we are closer to the end. There's more or less the indications are so far telling us. However, there is no immediate time frame to determine that end. Opportunistically, as Angela said, and as the Dr. Lucas say, we are targeting, we are telling countries, or at least working with them to say, use the methodology we use for the global estimation. We integrated it in a costing tool at the national level, used at the national level called the civic tool. And we said to them, play around with the combination of what we call the campaign modes. Is it only dependent on outreach, or is it a campaign specific approach, or is the opportunistic approach where somebody's coming for their hypertension pills, diabetic follow-up, you grab them, you seed them, and you say, I open a discussion with them about the COVID vaccination. Remember that these countries are struggling with their own set of endemic diseases and epidemic diseases. So COVID comes as an unwelcomed, it is unplanned for, even to find, as the Dr. Lucas said, to repurpose 11,000. They're trying to hire 10% increase on their current stock of 60 or 66,000. That's a huge resource mobilization effort for financing them, recruiting them, keeping them on the job. And one small point I will add, without the multilateralism that Angela spoke about, without partners almost guarding their investments by helping out with COVID in every which way, everything stands to be lost and dropped down. You know, it will completely lead to a sort of a regression. We will be toppling, or at least losing all the gains that have been established through time. And one last thought, and I'll stop. What we are seeing also is that countries are getting smarter. They're thinking of it as a continuum of investments towards primary healthcare, towards reorienting whatever the health system needs are. So unfortunately, the hidden blessing of dealing with a pandemic of this sheer size is the fact that, as Angela said, we do more with what we have. We gain efficiency. And this is not only a low-income country narrative. The high-income countries are doing more of the same. They're trying to prepare and to set aside that extra surge so that they can maintain essential services. This pulse survey that was conducted by WHO, and it's being done it's a survey that we check with member states, how is their progress during the response time. Health workforce shortages are being reported as the main cause of disruptions by almost 2/3 of these responding countries, in the range of about 120 to 130 countries. And they are the most vulnerable. So definitely it's too early maybe to target specific countries and say those ones are totally at a risk of collapse, because even the lower middle incomes are in trouble. The upper middle income, it's a matter of moderation between them on the point of time they are in, and given actually the flow or at least the progression of the pandemic and how it's affecting each society and each setting. So I think with that, I'm throwing out a bit of a provocative thinking that we have to think of utilizing what we have better. We have to set aside money. We have to set aside funding to rescue systems in these desperate situations as they arise. And we have to just keep focused on leveraging whatever exists on the ground best we can. Thank you very much, Alex.
Thank you so much. What strikes me is this dichotomy between the strength and resilience of health workers on the ground and almost the fragility of systems that we have built over time, and we continue to build it multilaterally and bilaterally, but we are at an inflection point in response to COVID. And I think all the points being made today are incredibly helpful in understanding the full picture of how worldwide pandemics can impact not just the people who contract a specific illness, but the people who are caring for them. So I appreciate your points today. I have a final question for Dr. Chukwuma McLeod. Follow up for Shafa in just a moment. So Dr. Chukwuma McLeod, how has COVID-19 impacted HIV prevention programming in Zambia? And how is JSI working with the government there to ensure workforce support?
Thank you, Alex. And very quickly, in Zambia, much as we've seen in JSI programs in other countries, the HIV prevention program has largely rebounded from the initial shock of the COVID-19 epidemic. Across Zambia, the Ministry of Health and its implementing partners quickly made some adjustment and adaptations to ensure continued delivery of HIV prevention services. To give the example of USA Discover Health, our community health workers are the backbone of HIV prevention programs. They know their local communities intimately, and they led the implementation of most of the COVID-19 adaptations at community level. For sure, subsequent COVID-19 waves have been challenging, particularly for services like VMMC that require in-person medical care. But thankfully, many of our programs have been able to use virtual, telehealth, and community-based strategies with great success for client support. I think the many years of PEPFAR investments in health systems have led to resilient HIV service delivery platforms. And as a result, we've been able to continue serving clients with HIV prevention services. Through the PEPFAR APA funds, we were also able to increase the number of our community health workers and reduce the burden and strain on this absolutely critical part of the health workforce. So we've been resilient to some degree and continue to safeguard those gains and investments. Thank you.
Thank you so much. Shafa, I want to get some more information from you, if I can. You talked in your presentation about how global COVID vaccination varies across gender and what the eventual cost of not vaccinating the world now is. But I'd like to get a little more information from you about what the return on investment would be of shoring up the global health workforce in delivery of COVID vaccines.
Sure, yeah, and thank you again for this panel. So in our studies, we looked at costing. We looked at comprehensive data on costing. We also did some estimation on the potential risks to economies, economic losses, if investments are not made robustly and comprehensively. And I put those resources in the chat, so there's more details that others can access. Return on investment, we didn't study that aspect specifically in our methodology, but we do know what the cost benefits are, and we do know what the trade-offs are of investing comprehensively in COVID-19 vaccination. And I think the top line of our report is, all of our fates are essentially tied. Our global economies are dependent. And when we have contexts where there's food insecurity, where schooling is limited, where employment is limited, we're going to bear those economic impacts. And wealthy economies often bear those costs more fully. So we see the opportunities in robust systems that are able to engage communities when we fully invest in frontline health workers. So we have part of that information. And I've shared those resources in the chat. I also just want to take the opportunity. I think Victoria asked an excellent question in the chat about community engagement. And, I mentioned that this is often an ongoing dialogue. People's minds don't change over time and don't change in just one session. And often concerns are legitimate. And, we learned very quickly in our COVID work, including in the US, that simply dismissing people's concerns is not effective. Even health workers had many concerns that required extensive engagement. Engagement is often thought of as quite nebulous, so I'm also going to share a resource in the chat that we use. That's a structured approach to facilitate a dialogue. We actually use this for all of our behavior change programs, even prior to COVID, but we're able to adapt it for COVID. So I'm going to add that now.
Thank you so much especially for touching on the community engagement piece. I'd love to get the other panelists' thoughts about community engagement, specifically what Victoria brought up in the chat. There was a question about faith communities and faith-based leaders, how to, let's see, essentially, how do we successfully engage with faith-based communities who may have some resistance to getting involved with vaccination efforts. And I wonder what that looks like at WHO and JSI and even PEPFAR.
Alex, I can go first if you wish me to.
Oh, sure, please.
Thank you very much. So I think, as all the panelists have emphasized, community engagement is almost the heart and lungs of getting anything to come into society and be accepted. And WHO pays a special attention on how community health workers, contribution-wise, who are they, what do they do, their profiles, their areas of engagement, over and above the conventional thinking around where they were first introduced from HIV to TB to malaria services, to actually extending their touch and their influence in the non-communicable diseases, the endemic diseases, raising awareness and the rest of it. And we have produced in Health Workforce a specific guidance on the more or less summarizing the characteristics of these community health workers, their competencies, and how to, in a way, nurture their contribution and their engagements where they work. What we noted, I'll give you an example. When we started to do our estimations, which uses, by the way, a labor-based sort of calculation, it's called the workload indicators for staffing norms technique, we did not have an idea how long it takes to administer a vaccine. Simply because, as you've heard from the panelists, we know how to do it in routine immunization campaigns for children under the age of 5. It's a simple matter, a campaign day or whatever is announced. Children are brought in by their parents or caretakers. It's a 2-minute process, and that should do it. We needed to listen to what is happening on the ground. And to do that, many countries, one of them is India, and others are also in the mix, they started to depend on those community engagement workforce to be able to transmit back to us what are the common or the sort of the average time needed to make somebody understand what goes on, especially the elderly. The idea that you have to set them up properly, and the idea that you have to gently introduce the concept, give them time, they have to be seated, they have to be relaxed, and then for the vaccine to be administered. So relaying that information helped us to tune our estimation. If it's an outreach, it will take so long per dose administration. If it's an in-facility administration, it will take an average of 10 to 15 minutes. If it's a mobile clinic, it will take approximately between 15 to 20 minutes to let the people in and out and register them and sign their cards. So for me, I'm focused more on them bringing the intelligence, the real life experience, to give meaning and sense and nuance to our estimation methods. Because an estimate is as good as the information being fed into it, given the reality of where we are making the influence. So that I feel strongly about. And we were walking in the dark. You have to understand that even for the high income countries, we were approaching the UK, we were approaching Germany, show us how it operates. They were always giving us very conservative estimates because they allocated big vaccination, how could I call them, centers who had like 100 vaccinators at the time. And they were like a factory line. People were just booking, coming in, getting vaccinated and leaving. That is a huge resource mobilization effort, which would not exist in the countries we have to worry about. So for me, the information garnered from those community engagements were definitely a live feed that improved on our estimation method and results. Thank you, Alex.
Thank you so much. I really appreciate that we're ending on a note about community, because that is why we're all here. And communities are what drive health responses and the success of health campaigns. I am sad to report that we are out of time for today's session, but I want to thank each and every one of you for joining us today, and to our excellent panel of folks, Dr. Chikuba McLeod, Dr. Siam Sheva, and Anjali. Thank you so much for joining us. If anyone who is a participant today that has any more questions, please feel free to send those to me, policy@iapac.org. So policy@iapac.org, and I will work to get those answers for you. Again, thank you so much for joining us, and have a wonderful day. Thank you.
You too. Thanks very much.
Thank you.
Thank you. Bye-bye.